Welcome to Make America Healthy Again. Join Dr. Charles Antinori and friends as they share solutions, tips, and insights that only doctors know for creating better health. Here's Dr. Antinori.
This is the Make America Healthy Again podcast. This is Dr. Antinori. Today my guest is Dr. Charles McCann, one of our attending surgeons in Inspira. He's in charge of the robotic system, and we're going to be discussing mostly robotic surgery today. Charles, you want to just give a little introduction about your background and things like that?
Sure, yeah. So I trained at Inspira as a resident, and I did my fellowship in minimally invasive and bariatric surgery out at St. Luke's Hospital in Kansas City. Mm-hmm. And I came back to Inspira to kind of help bring up the robotic program and kind of have a little bit more adoption within the system. Great.
We were just talking about, the discussion before we went on about the pros and cons of using the robotic system all the time, knowing that it, to a certain extent, many people believe it's more expensive, but want to have that, let's go over that again.
Yeah. So, robotics has been around for the last 15 years or so, in terms of, mass market adoption.
Right.
Early on, it was really specific for, pelvic surgery, being in tight spaces.
Let me fill you in a little on that. Cooper, the first time I saw a robot, the Cooper Women's Auxiliary, they have like a ball every year and they raise money. And they bought a robot for Cooper. It must have been about 1998, 2000, like that. And they sat it in the hospital and it sat in the lobby for a while and you could play with it. And then it sat in the OR and really nobody used it. I left Cooper in 2004. But for the first year or two, people played with it, but nobody wanted to do anything on it. They wanted the heart surgeons to try to take the mammary with it and stuff like that, and nobody really was interested in that. But then the urologists basically are the ones that started. A guy named Diamond started doing I guess he started doing prostatectomies or node dissections and things like that robotically, and very quickly it took over the prostatectomy world. I think this backed off actually a little bit on that the results, initially they were trying to claim that the results were way, way better. I think it turned out the results are kind of about the same, but it still might be a better way to do it. But that's what got the ball rolling. And then as time went on, more and more people picked it up. Yeah.
Yeah, and it started with, pelvic surgery, and then, as the technology got better and as the adoption, was more widespread, it expanded to other, fields of general surgery as well. I would say most common operation done on the robot now is probably gallbladder surgery.
Yeah.
And to your point, a lot of people make the argument, is it more expensive to do a gallbladder robotically? Is the reimbursement any different? No. Right. So it doesn't, there's no different code, billing code for a robotic gallbladder versus a lap gallbladder.
Right. Yeah. Still not. Yeah. Wow.
Exactly the same. And so the goal is to get the cost of the robotic gallbladder down as low as you can.
Right.
And the way that we do that is one, you can use very limited number of instruments, and we try and keep our trays as limited as possible just to keep the cost for the hospital down. I do a lot of my gallbladders now with just 2 hands and a camera. So it's a 3-port gallbladder.
Wow.
It cuts down on 1 instrument. It's 1 less incision for the patient. It's faster recovery. And so that is one of the arguments that we make that, it's acceptable to do these gallbladders.
Let me just stop you again and point something out. When I went down to Houston for my thoracic training, it was like Houston, Dr. DeBakey and Dr. Cooley were doing tremendous number of hearts, like way more than anybody else at that. I guess the Cleveland Clinic was about the only other place at the time that was really doing anything comparable in terms of number of heart surgery. And it wasn't like these guys were were that faster or, so much better surgeons or anything. But basically they, especially Dr. Cooley, who was, most people thought was like the better one technically, had trimmed it down to the minimum, just like you said, same instruments, limited, only the instruments going to use. Typically in general surgery and everything, they open up trays and have 40 things in there that nobody's touched in 5 years,
Right.
And that was the secret. And then the other thing was doing the same thing over and over again, just trying to have it, just the same procedure with as much as possible, the same nurses, the same technicians, as much as possible. That all adds tremendously to the speed,
Yeah, and with doing it that often, our time in the operating room is down real low. If you think
Yeah.
about it, it doesn't matter the complexity of the gallbladder. We don't have many that last more than 40 minutes.
Yeah.
And so, from a average, over the course of all these different cases that you have, there is cost savings, even if it isn't on the individual case.
Right.
Why Inspira has bought in so well to it, and why they allow us to do these acute care surgery cases on the robot is because we've shown that over time there is, cost savings because of it.
Yeah. Yeah. Well, I can say, like, as I've talked to, Chris Bashan, and the point is, if you save one open or with a long admission, and you and I have had a few of those, that drives up cost tremendously and makes up for a lot. And I'm sure, as I say, the robot's about $2 million, I think, something like that, the basic robot. But you can do thousands of cases with it. I mean, you do have to buy the arms and everything periodically. I don't, but if you do thousands of cases, the per case cost goes down to $100 or something like that, and that kind of can pretty easily get lost in the giant bundle of and the way people are paid. I've just been reading this book, Who Has the Best Healthcare System, and comparing like the United States and some of the Scandinavian countries and China and Japan, and everybody's using DRGs. I remember when DRGs started. It was early in my career, like the early '80s. It was when they went with DRGs. So the hospital gets a set amount of money for pretty much every procedure, and if it can do it for less than that, they make money. If it goes over, they lose money. So if you can, and like I say, and they're going to get the same amount of money for a laparoscopic cholecystectomy and somebody that has to be opened and then stay in a hospital for 3 weeks. They're still going to get pretty much the same payment. I think they can put some complexity in there, but
we see that more with colon cases, right? Mm-hmm. You think about perforated diverticulitis and real bad things that would be like either a Hartman's or you reverse them, whatever. Yeah, all of that adds time, pain, length of stay,
right.
The benefit of doing all those simple ACS cases, gallbladders and everything like that, is that you become more facile on the robot to do those more complex cases, right? So it's an indirect cost that you're saving there, but we're doing acute diverticulitis, perforated diverticulitis that normally be in open Hartman's, and we're able to do a robotic laparoscopic, segmental colectomy, put them together, and maybe do a loop ileostomy or anything like that, and save them multiple days in the hospital and hospital cost as well.
That's interesting. That really is
able to kind of be facile with the robot and be comfortable in that space without having a high conversion rate.
Right. It's another thing I had to learn. Again, I did the first. I finished residency I finished medical school in 1973. And, finished residency in 1980, and then the laparoscopic didn't come in until 89, 90 in kind of any sort of large numbers. That's when I think I took the course around 89 or 90. So I did 17 years of gallbladders done open, but when the biggest learning experience for me after we started doing laparoscopically is that I never realized that so many of the complications we saw from open cholecystectomy were because of the incision, not because of what you did inside. You always thought it was something to do with the operation that went wrong, or something like that. But I would say at least half of the classic thing, you write lower lobe pneumonia that we used to always, talk about, that was from splinting, which is not really going to happen with a couple poke holes,
Yep.
Yeah. But so anyway, you were talking too about the training aspect, huh?
Yeah. So, training in robotics is particularly with regards to residency training, is different than laparoscopic surgery, right? In laparoscopic surgery, you're attending and resident are opposite the table to each other, right? One person is able to kind of do most of the dissection. The other person is either retracting or kind of pointing at things, kind of guiding the resident through the case. And in order to effectively teach and show them how you would do it or kind of get them through the case, oftentimes you'll have to walk to the other side of the table, take the controls for them for a little bit, and show them kind of how to get things done. Right now with the robot, there's the option for what's called a dual console, right? So it's kind of like a pilot and a co-pilot, flying a plane. Anytime the co-pilot wants to take over, they transition the controls and they can fly. Same thing is true for the surgery. So back and forth, you pass the controls. You can kind of walk the resident through a portion of the procedure. If they're having trouble, then they take over for the next part without you even having to leave your chair. And both people have their own console with 3D vision and all that sort of stuff.
Yeah.
The other side of thing is the simulation. As VR and all these computer simulations have gotten better and better, there is a simulation built into the consoles themselves that allow the residents off hours, while they're on call, et cetera, to practice knot tying and manipulating tissue and doing little games with putting rings on pegs and on all that sort of stuff to improve their dexterity that doesn't require you to be operating on patients in order to do so. Right. And that technology has gotten so much better. I mean, even when I started training 10 years ago, the technology is way more applicable to what we're doing now.
Yeah. It's interesting, Charles. I feel the same way. Like, I kind of feel like I didn't become, or me and my colleagues didn't become so much better surgeons, but technology just got so much better. Pacemakers got so much better, lines got so much better. Laparoscopic came along, and a lot of these things did not. Well, the laparoscopy did come from the surgical community. I mean, it kind of came from gynecology directly, but a lot of these things came like more from industry, people making better, stents, for example, stents in aortas, stents in coronary arteries. I mean, stuff like that. That's all just some mechanical engineer that comes up with that idea that knows that you put titanium inside of a thing, it'll expand and, and comes up with the idea. And then they amazingly can figure out a way to fold up a heart valve and put it in a 16 8 to 12 French.
Or like origami based, folding it
right.
up.
It's unbelievable what they do with.
The robotic platform, it's Intuitive is the company, but they have software updates, right? Like everything is pushed, like now cars, right? You get
Tesla's the same way.
That change the function of your car overnight.
Right.
The same thing happens with the robot, right? They have the ability to, now we have the ability to control the pressure in the abdomen from the console. You don't have to have a nurse, walk over and lower the pressure. You can record your cases, right? And watch them back just like you're watching game tape, on Monday morning after your football game, right?
Yeah.
It's very similar where you can kind of look back and see where you can improve in ways that you never could before.
Right. Yes, so many things like that. You mentioned knot tying. You brought up something in my mind. When robots first started, this was a long time ago. This is probably in the 90s. I remember one of the guys was writing about they had started doing mitral valves, robotically. And what the guy said, the biggest bugaboo was tying the knots, because some guys would run valves, but most people didn't like to run valves. So if you ran it, you would only have maybe 3, 4, 5 knots. But most people put the sutures in individually, and it usually ended up being like 10, 12, 13, 15, knots that you had to tie. And he said, I remember the article I read said that like the fastest anybody's been able to get was like a minute, 3 minutes or something to tie a knot robotically, whereas, you can throw 6 half hitches in, a few seconds,
Sure. Yeah, I think, and just like you mentioned before, with how technology makes us better, not necessarily us getting that much better.
Right.
That's where the barbed suture comes into play.
I was going to ask you. So it's not so much knot tying anymore. It's more the barbed suture. Huh? Yeah.
Yeah, I mean, we do knot tie, right? Like I would say for a lot of my gastric bypasses, I'll throw some stitches with like a vicryl suture and tie those knots. But I'll use VLOC, routinely on hernia cases and suturing in mesh and that sort of stuff. And it's just a good technology. It's a one-way suture. It's barbed just like a porcupine quill. It can only go in one direction, and it keeps the tension. No matter.
That's what I'm going to say. I've only been introduced to it. I never really I may have used it once or twice, so I didn't really have enough real experience. So it is panning out that it's holding. I always was wondering about whether it maintained the tension, but yeah.
Yeah. I mean, I think the big point of failure, right, when you look at different hernia studies, has always been the type of suture, the suture ratio to the tissue ratio, and then the type of knot and whether the knot was square. So if you take out one of those things, right, the knot, then you're just worried about tissue strength and the ratio of how far you're traveling versus how long the wound is, et cetera. And the suture has gotten so good that you're really able to put a decent amount of tension on it, and it holds that tension, right? I do a lot of abdominal wall reconstruction, and you'll be amazed as to kind of how much distance you can close that gap. Good barbed suture. Now you can tighten it down, sequentially, which helps, right? Versus if you were to try to throw a stitch, you'd have to, tighten it in a couple different spots, right? In order to get the gap to close. Now you can just keep running it and slowly cinch it down, just like a zipper.
Wow. Yeah.
And hold tension, and then if you need to apply more tension, you can pull even more.
Are you able to get the rectus muscles pretty close to each other with this?
Every case. That's the goal.
Yeah.
If I can't do that, I'm doing some kind of component release to make that happen.
Because I again, doing them open, I found out that was really the important thing. Rather than just put a piece of mesh in there, you're just putting a sheet on the hernia, basically.
And it's either that mesh is either going to eventrate and just kind of slap into the hernia and cause trauma, pain, problems, or the hernia borders are eventually going to extend beyond the borders of the mesh, right? There's only such a big piece of mesh that you can put in there where you're going to solve that. You need to restore the function of the abdominal wall, to really fix that.
Right, sitting, and they talk about it, and we never used to talk about it, but when they started doing these things, they talk about like simple things like sitting up and stuff like that. If your rectus is way out laterally, even if you patched a hernia, it's not really a very effective repair. It really is interesting how the technology has progressed. I don't know. You probably don't have too much contact with the chest. I know the guys up at Cooper were doing most of their hearts. I mean, most of their lungs, via thoracic robot.
Yeah, we have the Cooper guys are coming to Mullica Hill now.
Is that right? Yeah.
Churcher is down here. He's doing robotic, VATs and lobectomies. I think he's doing it almost all robotically. Just for the fact that it's easier on the surgeon. It's a quicker surgery, and they've been having good results. Yeah,
that's it. And I think that they try to keep the incisions all in the same interspace. Have you ever seen them do that? I know they would.
Yeah.
I've seen them give a lecture and they talk about that. That would seem to make sense to me. In a way, if you're in like 4 different interspaces, it might actually hurt more. Than like a thoracotomy, which is 1 interspace. But
you just do one nerve block basically, right? You don't have to worry about treating the whole rib cage.
Yeah. The other thing you just touched on that we wanted to talk about was the surgeon longevity. You were saying, and that the robot.
Yeah, I mean, so the benefit of the robot there is, the way that it works is that the robot docks to the ports on the patient, right? The robotic arms are taking all the work, right? The resistance against the abdominal wall, as thicker patients that have higher BMIs, their abdominal wall can be 5-6 inches thick, right? And laparoscopically, you'd be torquing a very flexible instrument against that abdominal wall, trying to do the work that you need to do, and even open worse, right? You're trying to kind of fit a buckwalter to retract you. That gets to you after a long time, right? Surgeons are known for having cervical spine issues and carpal tunnel and all that sort of stuff. What the robot does is, it attaches to those trocars. It does all of the resistance itself, and then translate it to the console. And the console, no matter what you're doing, it's the same resistance. Now, there's new technology.
How much proprioception do they have that how much pressure you place? That was another criticism in the past.
Yeah, there's two ways. One is what they call visual haptics. So haptics just being kind of sensation of force, and that's more being comfortable with the robot, and same with laparoscopic surgery, where you kind of feel it because your mind can see how the tissue is moving, and you kind of anticipate what is tension based on kind of how things are moving. That's the visual haptics aspect. There's a new technology that just came out this year with the DV5, which is the robots that we use at Inspira, that actually has force feedback. And so it's a special kind of instrument where it will give you actually a readout of the amount of newtons of force applied with each, instrument. And so you can use it to say, okay, I want to set a max force of, 5 newtons on this bowel so that I never grab it too hard and cause an enterotomy. And you can set a limit, and that's like a speed limit, right? Where it's not going to go above that.
This is on the instrument or on the robot?
This is on the robot settings.
The robot setting? Wow.
Yeah, robot settings so that hand does not go. It also has, it's called force feedback. So when I'm actually moving my hands in the console, the arm is resisting me. And so it prevents me from, being too strenuous. Like if I'm pulling on it like a piece of bowel to measure the bowel, whatever, it will stop me when it's too much tension on that piece.
Wow. Yeah, like you say, the technology, just mind-boggling.
Yeah, and same thing with, abdominal wall, right? You don't want that abdominal wall to come together with too much tension, because then it's just going to pull apart as soon as they wake up and cough, right?
Right.
So you can actually measure the pressure on the abdominal wall by, pulling on the suture. You know how much force you want that barbed suture to hold, and measure it, quantify it with that, that force counter on the instrument.
Wow, that is interesting. You touched on another thing. It just reminded me of one more thing about the surgeon longevity. I had 2 partners that had to retire at fairly early ages, like 50s. Both guys were guys that did almost purely heart surgery. Almost probably the average week for them was 8, 10, 12 hearts, taking down the mammary on virtually every case, and they had to wear the headlights, which used to be very heavy. The headlights, I guess you probably don't have to wear them that much if you're doing robotic surgery, but now, the headlights that I have used recently have gotten a lot lighter somehow, but technology has made them a lot better. But back in the 80s and 90s, the headlights were heavy. The cord weighed, the fiber optic cable that went to the headlight weighed a ton, and sort of pulled on you, and then wearing the loops, 2.5, some guys wear 3.5 power loops, so you had to like really focus. And they both went out with neck, basically, injuries. They had fusions and that sort of thing, and one had a fusion, worked for like another 10 years, and then got in trouble again, and packed it in.
I mean, the robot. It's very ergonomic, right? You're sitting in a comfortable desk chair at the robot. It has a whole different suite of ergonomic features. So it adjusts the height, the hand position, the pressure on your face from the actual console itself. All those things, I think, really will make surgeons that are kind of purely robotic last much longer, or not necessarily last much longer, but just, not have injuries.
I don't think it'd be purely robotic. I think if you just, do most of your cases that way. The other thing for people, if some lay people may watch this, I remember kind of bragging and in my own, not so much bragging to other people, but to myself, like surgeons would be the last people replaced by computers and robots. And I think we have to tell people that, the robot is really just an interface between the surgeon and the patient. This is not replacing the surgeon. The surgeons, it was designed by the Army so that the surgeon could be behind the lines and that sort of thing, but I don't think it's used that way very often.
They've started to. There've been a couple of cases now that they've gone transcontinental.
Really?
There was I think it was a prostatectomy actually that was done.
Yeah.
I forget where it was. I think it was U.S. to Europe. There is some like telehealth.
Much lag? Was there much,
you need a very good internet connection.
Yeah, I was going to say, because even phone calls, You know, it's not a long lag. It's probably a second maybe, but it's noticeable.
Yeah. I mean, I think the as low as you can get it down, New York to London, I think is probably like at least 80 milliseconds.
Yeah.
For the back and forth information cross. So it's not like you're talking to the moon, but it's still enough.
Right. It's amazing what you can notice.
Yeah, absolutely.
Yeah. Well, listen, I think, I don't know, anything else you wanted to bring up? Anything?
No, I mean, I think that we kind of touched on all the benefits of robotics. I think obviously there's a strong future in it in general surgery, and we're just kind of trying to be on the forefront as much as we can.
One thing we're mentioning the benefits is marketing. Marketing was a big issue for a while, and I think that it sounds like the content is caught up with the marketing now. Like I remember, doesn't University of Penn have like 30 robots or something like that? Yeah, they have a huge number, and they're no dummies. Yeah, but so I'd say you wouldn't go that all in unless you really thought there was some substantial benefit to it. Rather than, marketing, you could have like 2 robots or 5 robots or something.
Well, and to that extent, right? Patients are asking for it, right? Like patients come to my office asking for robotic surgery. They may not know what that even means.
Yeah, I'm sure they don't in most cases. Right?
They think the robot's doing the surgery or whatever their interpretation of it is. But if you don't offer that service, right, they're going to look somewhere else. Right. The patients have the ability, especially in this area where there's 6 hospitals, within a stone's throw away. Yeah. And they'll go find, the most advanced place. And so from a marketing standpoint and just from like a ability to offer a service, you need to have a strong robotic program.
It's funny. We went through the same thing with laparoscopic. The surgeons that, with my group was at that time maybe 8 guys. The Principato's group had a couple guys, and there was another 2 or 3 groups or smaller groups, a couple individual guys. Probably maybe 15 surgeons altogether bought the laparoscopic equipment for Cooper. It was like $5,000 back then, which sounded like a lot of money back then. But we said like the hospital was dragging its feet. How it is, they got to put it. What's the word they use? When they put something on when they want to buy something, if it's over $500 or something, it has to go into some fund that has to be approved by everybody.
Sure. Yeah,
I'm forgetting the term, but. So anyway, we realized that the way things were going around 1989, 1990, if you didn't start doing gallbladders laparoscopically, you wouldn't be doing gallbladders.
Sure. Yeah. And there's a learning curve, right? Like
right. And there's a learning curve besides, right?
Side of things in order to stay current.
Yeah. Thank you, Charles. It's really interesting. Good to talk to you again.
Yeah.
And hope I get to. I'll try to get up to a couple of your events up there every once in a while. It's not that far away.
Sounds good. We'd be happy to have you.
All right. Thanks again.
Yeah, take care.
We'll see you. Bye-bye.